Hello everyone, welcome back to Patho Excellence and our Endometrial Pathology learning series. Today we will explore a very important topic, endometrial precancerous lesions, focusing on endometrial glandular dysplasia and serous endometrial intraepithelial carcinoma. These lesions represent the earliest morphological and molecular warning signs of endometrial carcinoma, the stage where timely diagnosis can truly make a difference. Let's look closely at their microscopic features, diagnostic criteria, and how to differentiate it from benign mimics. So, these are the precursor lesions of serous endometrial carcinoma. Now, endometrial glandular dysplasia converted into serous endometrial intraepithelial carcinoma, and ultimately it is converted into serous endometrial carcinoma. So, these are the spectrum of lesions. So, what is the dysplasia? What is the definition in general? It is an abnormal proliferation and maturation of epithelial cells characterized by loss of uniformity, loss of cell polarity, and cytological atypia. It is considered a premalignant change which may progress to carcinoma in situ if persistent. So, in short, a reversible premalignant change where cells show atypia but remain confined above the basement membrane and no invasion. So, let's see first of all endometrial glandular dysplasia. So, by definition, it is a precancerous lesion of serous type of endometrial carcinoma, shows mild to moderate nuclear atypia, less severe than SEIC, but more atypical than reactive or atrophic endometrium. Hence, it represents a morphological and molecular intermediate between normal endometrium and SEIC. Now, pathogenesis seen mostly in postmenopausal women with atrophic endometrium, early precursor of serous carcinoma showing P53 mutation and belongs to type 2 endometrial carcinogenesis pathway, and it is independent of estrogen exposure. Microscopically, it is seen in background of atrophic endometrium, focal glands or surface epithelium involved and showing mild to moderate nuclear atypia in the form of nuclear enlargement, irregularity, hyperplasia, and occasional nucleoli. Polarity partially lost but no stromal invasion. Mitosis and apoptotic bodies may be seen. Cytological atypia is less severe than SEIC and basement membrane is intact. IHC panel we will discuss later in detail, which is P53, Ki67 and ERPR generally negative. Diagnosis: so focal glandular involvement showing mild to moderate atypia without invasion, or it is basement membrane is intact. So this is endometrial glandular dysplasia. So here in this section, in hyperview, we can see a single gland large in size showing two types of morphology. So in the upper left portion of the gland, we can see hyperplasia, partial loss of polarity, nuclear irregularity, and in the lower right portion show prominent nucleoli with loss of polarity, vesicular chromatin, and there is high NC ratio. So this section shows EmGD in the upper portion, and here the transit between these two pattern, and here it is the serous endometrial intraepithelial carcinoma. So the difference between these two is here mild to moderate atypia and it is here severe atypia. Now, serous endometrial intraepithelial carcinoma. So, by definition, non-invasive intraepithelial neoplastic lesions of endometrial surface or glands that show marked cytological atypia, identical to serous carcinoma but without stromal invasion. And it is the earliest morphologic precursor or in situ phase of uterine serous carcinoma. Arises from atrophic endometrium, so seen in postmenopausal women. TP53 mutation associated, showing either overexpression or complete loss or null phenomenon or null pattern of P50Z protein on IHC. It represents type 2 endometrial carcinoma precursor and unrelated to estrogen stimulation. In our previous video, we have discussed atypical hyperplasia, which is associated with the estrogen stimulation or excessive estrogen response. Now, frequently occurs in the background of endometrial atrophy or colic. Now, gross findings. Generally not visible grossly and sometimes may be seen as a minute roughened area or polypoid focus, occasionally found incidentally in hysterectomic specimens. Microscopically, surface epithelium and glandular lining are involved without stromal invasion. Marked nuclear atypia in the form of large pleomorphic hyperchromatic nuclei with prominent nucleoli, high nuclear to cytoplasmic ratio, loss of polarity and hobnailling, mitosis and apoptotic bodies often present. Architecture, if we see in low power, papillary, micropapillary or tufted growth pattern of atypical cells, underlying stroma appears uninvaded but may show reactive changes or disformation, and background mostly atrophic and may coexist with endometrial polyp, uterine serous carcinoma or extrauterine spread. So here in this section, we can see these are the gland enlargement and highly atypical cells or marked atypia of cells in the form of hyperchromasia, pleomorphism, columnar in loop and prominent apoptotic bodies are seen in this gland. So here highly atypia with scant cytoplasm. Here also in this section we can see glands showing highly atypical nuclei, showing hyperchromasia, pleomorphism, columnar appearance, very low cytoplasm showing high NC ratio, but we can see here abnormal mitotic figures and this area show discohesiveness. So cells are separated from each other showing a nuclear irregularity, prominent nucleoli, but the important feature is basement membrane is intact. So this is SEIC pattern and highly atypical glands. Now in this section we can see three types of glandular morphology. So these are the atrophic glands, right? This show mild to moderate atypia with high NC ratio, and these are the highly atypical glands showing some of the papillary tuft formation in few of the glands. So if we see here hyper view of this portion, we can easily appreciate this normal atrophic endometrial gland, endometrial glandular dysplastic features and highly atypical glands in form of high NC ratio, vesicular chromatin, prominent nucleoli, loss of polarity. So these are the SEIC features. So this is admixture of glandular dysplasia, intraepithelial carcinoma and resting endometrium. So histopathological features of all three we can see here, but remember the difference main is high NC mild to moderate atypia in endometrial glandular dysplasia, and here severe glandular dysplasia. Size of the cells are 2 to 3 times enlargement, 4 to 5 fold enlargement, polarity partially lost, here totally lost, cytoplasm may be increased or abundant in SEIC. Nuclear feature, if we see, hyperchromasia is prominent in SEIC. Chromatin evenly distributed in resting endometrium, fine to granular or coarse or vesicular in SEIC. Nucleoli prominent like serous carcinoma in SEIC, and apoptotic bodies are brisk in SEIC. The cribriform pattern may be present in SEIC while it is absent in resting endometrium and dysplasia. Now let's see this comparison in the form of histopathological section. So here this section A show resting endometrium showing atrophic glands and normal surface epithelium. While in section B, C and D, this black arrow shows atrophic normal gland, and compare this atypical gland with this normal gland in all three sections. We can easily appreciate this atypia, which is mild to moderate, loss of polarity, hyperchromasia. Few of the cells show high NC ratio. So this is EmGD pattern. Here also this gland shows highly atypical, mild to moderate atypia with hyperchromasia, columnar in looking nuclei, some hobnailing, loss of polarity. So again, same features in section B. So these are the EmGD pattern. Now in this section E, what we can see is important transition between this normal transition from normal atrophic gland to endometrial glandular dysplasia. So beautifully seen normal portion here and abnormal portion of the gland showing atypia. This section F, if we compare with this all four section, it is showing frankly malignant look of the nuclei, showing severe nuclear atypia, high NC ratio, vesicular chromatin, prominent nucleoli, hyperchromasia and loss of polarity, but the basement membrane is incomplete. So this is how you can differentiate EmGD resting at endometrium and serous endometrial carcinoma. Immunohistochemistry, if we see P53, Ki67, P16 and ERPR is useful. P53 showing either diffuse strong positivity, which is mutant or aberrant type, or complete loss or null phenomenon. Here it is strong diffuse or mutant type phenomenon. Ki67 increase in both but high in case of SEIC pattern. P16 often diffusely positive, here diffuse strong positive, and ERPR expression is reduced in EmGD and negative or weak in SEIC pattern. In this section, we can appreciate dysplastic change in the surface epithelium, whereas this gland show normal atrophic endometrium. If we see P53 staining, it is overexpression or called as diffuse strong positive nuclear staining. Here, surface epithelium showing the dysplasia, some of the gland showing dysplasia. So this is again showing diffuse strong positivity of nuclei with P53 staining, and these are the glands also showing immunohistochemical staining with P53, which is 4 more than 5. So now what is scoring of P53 IHC staining? So this is 0 to 5 score. We have to see positive tumor nuclei and we have to interpret So 0% means no staining, that is null or mutant phenomenon. Less than 10, 10 to 25%, 26 to 50, 51 to 75%. So this is called as wild type staining, where patchy moderate nuclear stain. So patchy, weak staining, and some of the nuclei show staining, then it is called wild type. Overexpression, as this is seen here, it is overexpression where more than 75% to 100% nuclei show strong uniform positivity. So it is called mutant pattern. Null phenomenon. So tumor cells are negative or stromal cells positive. So what are the different typical P53 pattern in different lesions we can see? So proliferative endometrium or secretory endometrium, endometrial hyperplasia, endometrioid carcinoma low grade show wild type of phenomenon. While SEIC as well as serous carcinoma show either diffuse or null phenomenon, which is abnormal pattern. Clear cell carcinoma, variable appearance, but carcinosarcoma usually abnormal. Here we can see serous endometrial intraepithelial carcinoma in this section showing different types of glands like resting or atrophic endometrial glands. We can compare this highly atypical glands showing atypia with high NC ratio, but basement membrane is intact. So, if we go for P53 stain here, these glands are lined by intraepithelial carcinomatous cell showing strong aberrant expression of P53 IHC marker, and these are the atrophic glands which are negative by P53. Same section is showing P16 strong diffuse positivity, and if we compare this atrophic gland, these are negative. Now, why we need to identify this intraepithelial SEIC? Because it is biologically aggressive, frequently associated with extrauterine spread. Either ovaries, peritoneum, or fallopian tubes can be associated or invaded by this SEIC. May coexist with invasive serous carcinoma or tubule intraepithelial carcinoma. So whenever we find this type of pattern, we have to go for extensive search of this type of foci in uterus, and it is managed like invasive serous carcinoma. So total hysterectomy with bilateral salpingo oophorectomy may be needed. Now, if we see differential diagnosis, atrophic endometrium easily identified by small inactive glands, small nuclei, uniformity, fine chromatin, where no atypia, low mitotic rate, and P53 scattered with nuclear staining. If reactive changes due to inflammation, curettage, or hormonal effect, where nuclear enlargement is there but with smooth contours, open chromatin, sometimes nucleoli present, but architecture is regular, no coarse chromatin or no pleomorphism, P53 wild type and Ki67 is mildly increased. EIN or atypical hyperplasia, which we have discussed in earlier video, where gland to stroma ratio is more than 1, cytological atypia similar to background and mostly in premenopausal, perimenopausal women. P53 wild type of staining. ERPR here is strongly positive, which is negative in SEIC, and background endometrium is hyperplastic in hyperplasia, where atrophic mostly in SEIC or EmGD pattern. Clear cell carcinoma or clear cell endometrial intraepithelial carcinoma, where the cells are showing clear cytoplasm, prominent nucleoli, papillary or tubular cystic pattern, but P53 may be mutant or wild type. Here, napsin A and HNF1B positive and negative in SEIC. Usually distinct morphology with clear cytoplasm is helpful. Now tubular metaplasia, where pseudostratified columnar cells with cilia, uniform oval nucleoli and may occur in atrophic endometrium but no atypia, no mitotic figure. P53 is wild type and Ki67 low. Invasive serous carcinoma, marked nuclear atypia, stromal invasion which is key feature, papillary, micropapillary or glandular pattern with desmoplasia and IHC panel P53 mutant and P16 diffuse. If we see endometrial carcinoma with serous-like atypia due to chemotherapy or radiation where there is nuclear enlargement, hyperplasia, atypia is not uniform, no true papillary pattern and P53 wild type or variable. So that's a concise overview of the two key precancerous lesions of endometrium, EGD and SEIC. Remember, careful attention to nuclear atypia, mitotic activity and P53 expression can help distinguish these lesions from reactive or metaplastic changes. If you found this video helpful, don't forget to like, share and subscribe to the channel for more short high-yield pathology discussion. See you in the next session where we continue to decode the microscopic features of endometrial carcinoma, very important topic. So stay tuned.